with me Professor Amir Gupta and Professor Chintan Malhotra from PGI. Both are very reputed corneal refractive surgeons. So we are very fortunate to have with us today in this program. So they will be discussing very important and basic things. So in this session we are going to discuss about corneal imaging and refractive corrections. So first speaker is Dr. Alisha Kishore. So she is an assistant professor in our college. She is from AIIMS Delhi, and she is going to speak on topic how to read a normal corneal tomography and topography. Dr. Alisha, please.
The corneal topography and tomography, how to read a normal scan. So topos means to place and graphy means to draw. So a corneal topography is a graphical representation of the geometrical properties of cornea. Whereas tomos means to cut or section. So a corneal tomography is an elevation based representation of cornea. So what is the need of a topography or a tomography? The keratometer measures the anterior radius of curvature of the cornea along the two principal meridian, which are at points located 3 to 3.2 mm apart on the paracentral region, assuming that the cornea is a perfect sphere. However, it is not sufficient in cases of refractive surgery and in diagnosing corneal ectasias, where the accurate analysis of the whole anterior as well as posterior surface of the cornea is required. So we have various techniques based on which we can do a corneal topography or a tomography. So the earlier which was used was the Placido based, which include devices including Placido disc and video keratoscope. Then we have the slit scanning system, which includes your OpScan, and then we have the latest shine plug imaging, which includes the Pentacam, CDS and Galileo. So the Placido-based devices, in this the cornea works like a convex mirror and the reflected image is viewed either directly or is captured and analyzed. The shape and the orientation of the mires, that gives an idea about the shape of the cornea. So this in the above example you can see that these are the mires of the Placido disc, and how much closely or far away the mires are will depict whether there is any steepening or flattening of the cornea. The corneal video keratoscope is a backlit Placido disc and a camera respectively to image the cornea instead of the indirect illumination and the observer's eye. So it measures the central and the mid-peripheral cornea. This is an example showing the map of a video keratoscope, wherein you see that the central area and the somewhat the mid-peripheral area is clearly shown in the axial curvature map, but the peripheral area of the cornea cannot be clearly visualized. The keratometry values are also depicted. Also in this, the elevation map can be extrapolated, however it doesn't give you the true elevation of the cornea. The next is the scanning slit system, in which the slit scanning and the triangulation they are used to derive the actual spatial location of the thousands of points on the corneal surface. A series of slit lamp beams are compiled across the cornea to create a profile of the cornea. So as you can see in this diagram, 20 slits towards the right and 20 slits towards the left are projected on the cornea. So a total of 40 slits are there. We use the concept of best fit sphere in these imaging techniques that will be used in OpScan as well as in Pentacam also. So what do we mean by that is that we have a reference surface with which we compare the data surface of the patient. Anything which will be above this reference surface will be depicted in warmer colors, that is it will be elevated, and anything which is below this reference surface will be depressed area and that will be represented by the cooler colors. As you can see in this diagram also, that this is the reference surface, anything which is anterior to it which will be depicted in warmer colors which is towards the red, and anything which is below will be depicted towards the cooler colors which is in your blue range. So this is a quad map that is shown on an OpScan, although it is not used nowadays, but we just have an overview wherein you have 4 maps, the anterior and the posterior elevation map. These are also not the true elevation maps, these are extrapolated. Then you have the curvature map, and then you have the pachymetry or the corneal thickness map. In the center you have the various parameters that can be seen, which includes your keratometry value, the pachymetry value, and apart from that you also get Y to Y diameter, pupil diameter, the thinnest pachymetry, AC depth. So what are the limitations of OpScan? It lags in accuracy and reproducibility as compared to a shine plug imaging devices. and inaccurately identifies the post-operative posterior corneal surface and routinely locates the surface to anteriorly. So what we are using nowadays is a shine plug imaging. The shine plug law says that to get a higher depth of focus, you move the three planes, that is the picture plane, the objective plane and the film plane, such that they cut each other in one line or at one point of intersection. So this basically gives you the true elevation. So this is a classical 4-map refractive map which is seen in a pentacam, in which you can see that on the top leftmost corner you have the patient details. Then on the left side over here you have all the parameters of the front cornea as well as the back cornea, which includes your keratometry value, the astigmatism. Then you have the values related to your corneal thickness, the pachymetry, and then you have certain other values. This we are going to discuss in detail in a while. The 4 maps that are depicted in this 4-map refractive map includes your axial or your sagittal curvature map, the anterior elevation, the posterior elevation and your corneal thickness map. So coming to the elevation maps, these are the two anterior and the posterior elevation map. The normal range is depicted by green color. So you can see that in these two maps, it is showing your normal elevation. Anything which will be above will be depicted by your cooler colors, that is the higher elevation, and anything below will be depicted with your warmer colors. So what you need to remember roughly the values is that normally the anterior elevation should be less than 12 microns, 13 to 15 micron is suspicious, and more than 15 micron is a risk factor for corneal ectasia. So in such cases you will be very cautious if you are planning a refractive surgery for such patients. Similarly, for the back surface, the normal value is less than 17 microns, 18 to 20 is suspicious, and more than 20 microns is a risk factor. Also, the difference between the anterior and the posterior surface should be less than 5 microns. Then coming to this sagittal curvature map, as you can see in this, also another important thing is that in all these 4 maps, if you see, you have a color coding scale on each of these maps. So it is important that you see this color coding scale and at which steps these color coding is being depicted. Why is it important? Because as you can see in this, it is showing that it is 1.5 diopter step in each color change. So more the step, that means for even a high, it will not depict the smaller value of change in the curvature. Whereas if the step is less, that means even the smaller change will be depicted by your color change. So this thing also you have to see very carefully before you read your map. Now this is a normal map, normal sagittal curvature map which is showing. As you can see that everything is green in color. There is a symmetric bow tie pattern that you can see. If there is any abnormality, you will see different types of patterns. So a flatter cornea will be depicted in cooler colors and a steeper cornea will be depicted by warmer colors. Then next is a pachymetry map. The pachymetry map also again you will see first of all your color scale. This is showing a normal pachymetry wherein you can see that everything is green in color and the peripheral cornea, as we all know, is slightly thicker. So that is why it is showing as blue. So this pentacam depicts the true thickness because it actually calculates the difference between the anterior and the posterior elevation, and the elevation which is calculated is actually the true value as compared to your previous techniques of op scan and your video keratoscope. So it provides a high accurate information about both the anterior as well as the posterior surface of the cornea. It generates around 25,000 data points to describe this true thickness. As compared to your manual ultrasound pachymetry, which only images at one single data point. Also, it is important that in your pachymetry map, you see the relationship between the apex of the cornea and the thinnest location. It should be ideally less than 10 microns. So this is the various parameters that are depicted on the left side of the map, as we have seen in the full map. So what all are depicted is that you have the K1 value, which is your horizontal curvature in the central 3 mm zone. Then you have the K2, which depicts the vertical curvature. Then you have the mean curvature in the central 3 mm zone. These all are in diopters. Then you have the amount of the corneal astigmatism which is present on the front surface of the cornea, and the minimum radius of curvature. On the other side, that is on the left side, it is showing the same values, but these are in millimeters. you have the mean curvature. Then again you have the axis is also depicted, that is the axis of the corneal astigmatism in the central 3 millimeter zone. And then you have the radius of curvature also in the peripheral area. Another important factor that you have to see in this map is the QS value, that is basically your quality specification value. Normally it should depict as OK. In this example you can see it is coming as blinking, that means you need to repeat this scan. Another value is the Q value. We will be discussing this in detail. This basically, roughly you should know that this basically depicts your spherical aberration, that is the asphericity. So normally it should be less than -0.5. The other values which are indicated includes your parameters, including parameters related to the corneal thickness. So you have the corneal thickness that is present in the pupillary center. The coordinates are also indicated, x and y, which basically indicates the position and considering the apex as the origin of the coordinates. Then you have the variable of the corneal thickness at the apex, the thinnest location. Then certain other values are also depicted. For example, the corneal volume is depicted. The anterior chamber volume is depicted, which should be, which if it is less than 100 millimeter cube, is a risk factor for angle closure glaucoma. The AC depth should be more than 2.8 millimeters. Then it also gives you the corrected IOP while considering the corneal thickness. The angle of the eye is also can be calculated in this, which if it is less than 25 degrees, a risk factor for angle closure glaucoma. The pupillary diameter can also be depicted, and the lens thickness is also calculated, but for that the pupil should be dilated. So as we have discussed the Q value, which was depicting your asphericity. So when the cornea is extremely prolate, normally the cornea is prolate in shape as you all know, but if it is extremely prolate, the peripheral rays will be focused behind the central rays, which causes a negative spherical aberration. Whereas in a case of an oblique cornea, the peripheral rays will be focused in front of the central rays, which is known as the positive spherical aberration. What you need to remember is that your Q value normally should be less than -0.5. Now in this pentacam we also have an enhanced ectasia displays, which was given by Bellin-Ambrosio. So we call it as BAD display or the Bellin-Ambrosio enhanced ectasia display. What the concept of enhanced best fit sphere was used in this. So what was the advantage in this case was, normally when a normal reference surface sphere is considered, since the cornea is not perfectly spherical in shape, so therefore this best fit sphere does not fit normal cornea exactly. That is why if there is a small elevation or a small change in the cornea, the early changes cannot be detected. But in the enhanced best fit sphere, a new reference shape was created considering the normative data of the patients. So therefore the advantage was that even if a small change was there, so the that elevation can be depicted on the map very clearly. So that was the advantage, that you can detect the early stage of the ectasia or the keratoconus. Now in this BAD display, the concept of D value was also there. So this is a new terminology wherein 5 terms are included in this, wherein the DF is the front surface, B is for the back surface of the cornea, P is the pachymetric progression, T is the thinnest point, Y is the thinnest point displacement. So what we need to remember in this one is that the D value, the total D value should be less than 1.6. Yes. The D value normally should be less than 1.6. Between 1.6 to 2.6 is suspicious, and more than 2.6 is abnormal. And also in this you have the percentage thickness increase, which should be between your 2 dashed lines, which indicates your 2 standard deviation. So just before concluding, I would just like to show this map, so that whenever this map is shown to you in your exam, how do you read it, that you should know. So if this is something which is shown to you, this is a pentacam 4-map refractive map of a patient named Kavita, whose keratometry value is 45.5 and 43.7 with the mean K of 44.6. The thinnest pachymetry is 539 micron with the Kmax of 45.7. In the sagittal curvature map, since everything is green in color, so this is showing a normal map. The anterior and posterior elevations are also normal, and the pachymetry map is also normal. In the BAD display, you can see that in the anterior and the posterior elevation, everything is green in color, so that means there is no abnormality in this. also the CTSP and the PTI profile is well within the normal range, and the D value is also 1.04, which is well within the normal range. Thank you.
Thank you, Dr. Alisha.